Next week, 7,000 healthcare leaders are going to walk into the George R. Brown Convention Center in Houston for ACHE 2026. Adam Grant is opening. Brene Brown is closing. Hundreds of sessions on AI strategy, leadership, innovation. And here's the question that will not be on any panel agenda. How many AI strategies presented in that ballroom have been tested by a real clinician, on a real patient, in a real workflow? Not a pilot, not a proof of concept, a real deployment at scale, under pressure. The gap between the stage and the floor is what this podcast is all about. I'm Dr. Sarah Madden. I'm a physician, healthcare strategy consultant, and the national bestselling author of The Borderless Healthcare Revolution. And this is The Clinical Realist, where we talk about what actually happens when healthcare meets technology, policy, and the humans who have to make it all work. So I've been going to ASHE a couple of years in a row. It's been a while, but it's one of the best healthcare conferences in the country. And I say that genuinely. The caliber of the room is different. These are the people who make actual decisions. System CEOs, CMOs, CFOs, board members, 7,000 of them in the same building for 3 days. But here's the pattern I see every year. Someone gets on stage and presents something shiny like an AI strategy, beautiful slides, compelling data, and the room nods. And then the same room goes back to their health system on Monday and runs into the exact same three walls. Wall one, the tool works in the demo, but not in an actual workflow. The EHR integration's clunky. The nursing staff was not trained. The patients don't trust it. But the pilot looked great. The deployment, though, looked nothing like the pilot. Wall two, there's no billing code. The CFO loved the efficiency gains until they realized that fee-for-service penalizes efficiency. A physician I know cut a patient visit from 40 minutes to 22 using an AI-assisted workflow. Better care, happier patient, but lower reimbursement. And that is the incentive structure we're working with here. Wall three, governance. Who actually owns the AI output? Who's liable when the algorithm is wrong? And who decides which tools are approved? And then there's the shadow AI problem where clinicians are using unapproved tools because, let's be honest, the approved ones can be worse. So these three walls are not new. They've been here for years. And every conference, we talk about the innovation as if the walls don't even exist. So let me put a number on wall two, because this is the one that kills the most promising work. There are currently 1,357 FDA-authorized AI devices in clinical care. And that number grows every single quarter. So the FDA, they're doing their job. Devices are getting cleared. Now here's the other number. How many of those 1,357 devices have a clear, robust reimbursement pathway through commercial insurers? Almost none. The AMA just created 26 new CPT codes for clinical AI. First time in AMA history. So that's a genuine milestone. And you know what? It's still a rounding error against 1,357 devices sitting on shelves because nobody can bill for them. So we built the authorization pathway without building the reimbursement pathway. And those two pathways have to travel together or the innovation just sits there. So this is not a technology problem. This is a policy design problem. And it's the conversation I most want to have at ACHE next week. So I'll give you a real example. I'm not going to name names, though. So a health system I've worked with deployed an AI-assisted radiology tool. The accuracy was way better than the baseline, and the turnaround time dropped significantly. The radiologists liked it. The patients benefited from it. But the expansion was killed in Q3 because the CFO could not justify the license cost against a reimbursement model that paid the same whether the AI was there or not. So the tool worked. The economics didn't. And that's the story playing out across hundreds of health systems right now. And the people presenting at conferences, they're showing you the pilot data, not the expansion data, because the expansion data is a CFO saying no. So I want to shift to something that has been in the news this month that I feel strongly about. So the CMS administrator has been talking about AI avatars as the solution to rural healthcare shortages. And the pitch is that AI could multiply physician reach fivefold. Oh, that sounds good. And that an AI avatar could actually deliver care in communities that don't have enough physicians. All right. Also sounds pretty good, right? But I have a different perspective. And I wrote about this in the Borderless Healthcare Revolution as well. I've sat with patients who've driven 90 minutes one way for a follow-up because they didn't trust anyone closer. That's not a bandwidth problem. That's a trust problem. And an AI avatar is not going to have solved that. A physician who knew her name and remembered her story and her history solved that problem. So the value of a rural physician is not the volume of information they carry. Databases carry information. The value is the relationship. Someone who has examined you, who remembers what you said the last time, who can read the things you're not saying. AI has a real role in rural care. There's no question. And it can extend reach for the humans already there. It can handle triage, documentation, follow-up scheduling, medication management. I mean, it can make a physician who serves 2,000 patients serve them better. But the diagnosis has to be right. And if we diagnose the rural healthcare crisis as an information distribution problem, well, we're going to invest in information distribution tools. And then we're going to wonder why outcomes don't actually improve. So the rural healthcare crisis is a workforce and trust problem. Fix the incentives that push physicians towards urban centers. Then let AI amplify what those physicians do when they get there. AI is absolutely a force multiplier, but it only multiplies something if something is already there. So here's what I'm carrying into Houston next week. I am looking for people who have hit one of these three walls and figured it out, how to get past it. Not the people with the beautiful pilot, no offense, guys, but the people with the ugly expansion, the CMO who went live and survived, the CFO who found a way to justify the cost, the governance lead who built a framework that actually works. Those conversations don't happen in the ballroom. They happen in the hallway between sessions when two people recognize each other's problem and sit down. So if you're going to be at ACHE, I want to hear your story. Find me. I'll be the one there asking the super uncomfortable follow-up questions. And if you're not going to ACHE, but you're navigating any of these are challenges that we're all facing. And that's what I want you to tell me about. I help health systems and digital health companies build AI strategies that survive contact with real clinical workflows. So my information is in the show notes. This is episode 5, I think, of The Clinical Realist. So thank you for listening. If this resonated, subscribe wherever you get podcasts. Follow me on LinkedIn, where I post about this stuff every single day. And if you have a story about hitting one of these walls, send it to me. I want to hear it. I'm Dr. Sarah Matz, and this is The Clinical Realist. See you next week.